Welcome to Module 5, Advancing Paramedic Practice and Contributing to the Body of Knowledge. This is the copyright notice. Please don't sell this on the internet. Nobody really wants it anyway, and you won't make any money. Now, the intended learning outcome for this module is to critically analyze and evaluate the professionalization of paramedicine and the concept of generating theory from practice. Two main parts of this learning outcome. The first one is about professionalization, and we're talking about that with registration, paramedics joining APRA, our fights to become part of the other health professions or one of the other health professions, and we spent a lot of time talking about that already in the forum. So I'm going to focus on the second part of this learning outcome, which is the concept of generating theory from practice. Now let's talk about theory. I'm sure you're all very excited like these guys to talk about theory. But it's quite simple, and it's only going to be very basic and hopefully in terms that we can all understand without getting caught up in some of the language. So what is a theory? Well, a theory or theories are composed of concepts, definitions, models, propositions, and are based on assumptions. And of course, Albert Einstein had some famous theories. When we are looking at theories and trying to apply them to what we do, we need to contemplate what is our practice? What are we specifically doing as paramedics? What is our identity? And are we a discipline? So what is a discipline? Well, it's a formal body of knowledge, essentially. And a discipline has expertise, people, projects, communities, studies, inquiry, research, and is connected with study and professional practice. So as paramedics, are we a discipline? Well, let's take a look at each one of those. Do we have expertise? Certainly we do. We are experts in out-of-hospital emergency medicine, and arguably inter-hospital emergency medicine, and even retrieval medicine from hospitals to other hospitals. I guess that is inter-hospital. We are paramedics. That's the people that we are, and in Australia at least, we're the most trusted profession, and quite proud of that. The communities we serve and the communities we work with, well, out-of-hospital emergency care, we are a community of practice, and we work with the other emergency services to do our jobs. Studies, well, we used to go to TAFE. That used to be the pathway to becoming a paramedic, and that's changing rapidly to now we're at universities. And in fact, many of you in this subject are in postgraduate education. So you've finished your basic undergraduate degree and are moving into postgraduate studies. And postgraduate studies are becoming the standard for those specialist roles like ECPs and ICPs. So our discipline is rapidly becoming highly educated. And do we have inquiry and research? Certainly we do. We do clinical science studies, we're basing our practice on evidence, and moving forward as a profession, as a discipline that uses science and evidence to inform what we do. Now let's look at our identity. The identity of paramedicine is still evolving, and Peter O'Meara, who used to be a professor here at CSU and moved on to La Trobe University, is probably one of the most prolific authors and researchers in paramedic practice in the country. And Peter says that there's a lack of reflective literature examining our place and role in society. And what he's saying really is that paramedics are having a difficult time articulating what it is that we do that's special, or what's different, or what's unique to other health professions. He also goes on to say that we really need to underpin our professional identity by developing more theories of our practice and ensuring that we are publishing that so that we can tell other people about it. In this paper, which is just a quick editorial, and I strongly encourage you to read it, he refers to a writing or a way of looking at our professional practice as doing, knowing, being, and becoming. And what's interesting about this is it's that whole spectrum. It's easy to look at paramedics as being a doing profession. We're known to be pragmatic and be very skills focused. But the concept of becoming gives us hope, gives us something to strive for and something to look forward to, and allows us to keep growing. And I think that is something that's really important when we look at what frames our identity. What is a theory of practice? We talked about theory, we talked about our discipline and our practice, and now it's a theory of practice. Well, it's attempts to describe or explain the phenomenon, the process, occurrence, and event of a discipline. In other words, we're trying to explain what it is that makes paramedicine, which is the discipline here, unique. Now, are you lost, confused, unsure, unclear, perplexed, disoriented, bewildered? Well, let me try to use something that most of you will probably be able to understand. So let's look at this lady, Florence Nightingale. And we all know Florence Nightingale as being a nurse, of course, back from the 1820s all the way through to 1910 when she passed away. And she was really the founder of modern nursing. She's well known worldwide by everybody, particularly nurses who study Florence Nightingale, as well as Roman sewers and all kinds of other things. She became a manager, and she trained nurses during the Crimean War. And she tended to wounded soldiers and really became highly, a great reputation as a healer and somebody that's very special, and became a sort of icon of Victorian culture. And she's of course known as the Lady of the Lamp for making her rounds of the soldiers at night. Now, Florence Nightingale, in addition to being sort of the founder of modern nursing and known to be an exceptional educator, was also a philosopher. And she came up with a philosophy of nursing, a theory of nursing practice. And this one is quite simple. And there's literally dozens, if not probably hundreds, of theories of nursing. And paramedicine, of course, doesn't have that history. And this one of Nightingale's is quite interesting. So this is Nightingale's environmental theory from 1860. Nursing is an act of utilizing the environment of the patient to assist him in his recovery, that it involves the nurse's initiative to configure environmental settings appropriate for the gradual restoration of the patient's health, and that external factors associated with the patient's surroundings affect life or biologic and physiologic processes and his development. Now, what Nightingale is doing by her environmental theory is differentiating the role of doctors of the time with the nurses, creating a professional space to occupy. And she's concerned with, and believes that nursing is concerned with, things like making pure fresh air around the patients, and pure water, and effective drainage, and the cleanliness, and the food they drink, and access to, food they eat and drink, and access to sunlight. And all of those things improve the patient's health and help them heal from disease over time. Now, we know from science now that all of that's true, and doing those things is evidence-based practice. But at the time, Nightingale found a gap in something that the doctors weren't concerning themselves with, that nurses did exceptionally well, thereby creating a theory of their practice that they could call their own. So, what is the paramedic theory of practice? And where would you start looking for it if you wondered what it was? We would look at the journals to find theories of paramedic practice, or things that would inform our identity. And we would find that there's a lot of information published about the skills that we do. Our response times in ambulances, the outcomes of cardiac arrests, maybe even patient satisfaction, maybe even the effectiveness of some of the medications we give. But we don't find theories of paramedic practice published in the literature. And certainly before 2008, we didn't see any. In 2008, Dr. Anthony Campo, and Tony Campo is a paramedic from Canada who did his PhD in this area, wrote a paper on why paramedics require theories of practice, which I've posted for you online. And he says that professional knowledge is the bedrock of competence, and to fully capture paramedic knowledge, one needs theory. So what Campo did is he also said that occupational knowledge is not static, and it's important for paramedics to establish their knowledge as the various aspects of their work change. Such work would help differentiate paramedic practice from the related professions. And that's an important one. We need to establish ourselves and our knowledge in something that's unique, that differentiates us from other health professions. Now, the people in this subject are from all kinds of different backgrounds. We've got some experienced paramedics that maybe came through a vocational pathway or an undergraduate pathway and are doing a variety of roles. Many are training to be intensive care paramedics or managers and leaders. Some of you are nurses from very many different backgrounds and all over the hospital and in and out of the hospital. And you come with a whole set of specializations. Now, certainly you will be able to think about things that make paramedics different than other health professions. Let's do some examples. Starting a cannula. Well, a lot of professions do that. That's not unique to paramedicine. Moving on. Managing an airway. Well, bagging a patient, managing an airway from basic maneuvers, even with LMAs, even with endotracheal intubation or RSI, not unique to paramedicine. Putting on a splint. In fact, I would argue that paramedics are quite bad at this. Give me a St. John ambulance provider any day over a paramedic to put on a splint. Certainly much better than me. And giving drugs or medications, not unique to us. Using a LifePak 15 or any other kind of monitor, defibrillator, cardioverter, patient care monitor, again, not unique to us. Doing point-of-care testing. This is just sugar, but what if it was troponins or lactates? Yep, not unique to paramedics. Even something as, paramedic-like, like spinal immobilization and extrication, not unique to us. Lifeguards do this, firefighters do this, SCS members do this, ski patrollers do this. That's not just us. Even the invasive things like intubation, that's not unique to us. But it's in the back of an ambulance. Maybe that's different. Now what Campo did with his PhD, which he's published and I've posted it online, is said some interesting things that help differentiate us. He said that unlike other health professionals, paramedics do not have a predetermined work area. When we show up to the station in the morning, we have no idea where we're going to work that day. We have to be prepared literally for anything. And what we're good at is adapting ourselves to the environment and making sure that the environment suits the patient and the patient care accordingly. And we've got a lot of decisions to make to ensure that this happens safely. Campo tells us that paramedics are concerned with establishing control over their immediate workspace in order to create an environment that supports the delivery of emergency patient care. His concept is space control theory, and that paramedics use space control theory to create a safety zone for the patient, to reduce uncertainty through social relations, which essentially just means using communication with the patient, the bystanders, the police, the fireys, the SES. Controlling the trajectory of the scene. In other words, we've got to get from point A to point B. Point A being the scene, point B being the hospital, and we've got to make sure that we move in that direction, regardless of what's going on the scene or what decisions have to be made in between. The temporality of the scene. We need to decide, do we spend time on the scene or do we go quickly to the hospital? And if so, what do we do now, meaning on the scene and urgently, and what can wait till later? And collateral monitoring. Always monitoring for changes that happen on the scene, whether it's to the patient or the scene itself. Always monitoring everything around us and in fact everything that we do. So Campo wrote this up in his thesis. I strongly encourage you to read some of these papers. I find it absolutely fascinating. It was done in Ontario, Canada, and the paramedics provided a lot of insight in what's unique to paramedic practice. So we looked at all those skills, realizing that a lot of those skills that paramedics do every day are definitely not unique. Other health professions do those all the time, nurses, doctors, allied health, but let's look at some other pictures and see if these are unique to paramedics. So we provide care. This is spinal mobilization, which I said lots of other people do, but we do it in dynamic environments. We do it in the middle of the street. We do it in the bush. We do it busy intersections. We do it with bystanders around. We do it with lots of other emergency services. We have some pretty strange collisions that we go to, and we use our allied health, or we use other supporters like SES, fire, rescue, VRE, other people that help us access patients in these unique environments. We provide patient care in pretty austere locations and environments, side of the road, on a stretcher, in a small space, or even indeed in the confined space of an ambulance or a helicopter. We go to trains, under trains, in between trains, to rescue patients, extricate patients, provide treatments, start cannulas, and do a whole bunch of different interventions that are done by other health professionals, but not in the same locations that we do. We do it in the public, we do it where it's very visible, we have to always maintain our image, our composure, our communication, and we're looked at by everybody because we're not in the confines of a hospital or a resuscitation room or a doctor's surgery. We are doing it on a beach or in public, or in a hole or a pit, or on a sports field with other providers of pre-hospital care. And again, using our skills and our equipment in very difficult places, like the back of a confined helicopter. We work around people that are potentially dangerous, creating hazards and hazardous situations where we need to use specialized equipment. We often think that paramedics only work in ambulances on the street, but we know that paramedics more and more are working in industry, in mines, underground, and offshore, and on oil rigs, and on seismic vessels. And in this case, providing care to a patient in a mine. We go to places that no other health profession goes to treat patients. Back alleys, drug houses, crack houses, into ice labs, and sides of cliffs, or in other austere environments. We, again, do our provision of care in the most difficult and most outrageous locations, with some difficult and outrageous people, and not always popular with the locals, but always providing good quality, evidence-based, where possible, patient care. And where we do it is sometimes in these extreme environments I showed you, but in almost every circumstance, we're doing it in the environment that no other health professional generally gets to go. And that's the privacy of a patient's home, or the sanctity of their bedroom. One of the great things about being a paramedic is to go into these places to see where people live, where they work, how they behave, how they act, and what they keep in their bedside drawer. And, family photos. Moving on. So what do you think about space control theory? Does this make sense to you? Do you think that Campo's onto something? And again, to recap, paramedics do by and large, the same clinical procedures, follow the same protocols, give the same medications as many other health professions. Nothing there is unique. If it was, we wouldn't need to do specialized paramedic education. If you come through a nursing course or a medicine course or physiotherapy or pharmacy course, you could probably pick up a lot of those skills and procedures. But what Campo says is that the decision making, the scene management, manipulating the environment, communication skills are all unique to the paramedic. What do you think about that? Now, that leads to some big questions, like, how do we teach it? Well, let me tell you, I have no idea. We don't really teach this. I have to say that in all of the lectures that I give this one, but I don't really give students the lecture about how to manage a scene. It would be impossible to teach students how to manage every possible situation they'll face. Our best bet is to make paramedics resilient, use good judgment, solve problems, be critical thinkers, use evidence, have strong theoretical frameworks, and most importantly, and what many of you do all the time, is have good mentors. We put our paramedics with good paramedics to learn. And those students reflect on what they see, reflect on what they do, and gradually build up their confidence, their competence, and that whole library of skills and experience that inform their intuition and good judgment. And that's the best thing we can do to prepare paramedics for their unique role as, again, very unique professions. So in summary, we set out today to critically analyze and evaluate the professionalization of paramedics. We didn't really do that because we're covering that in other ways when we talk about registration. But I put in here my focus on the concept of generating theory from practice. We're practicing paramedicine in the field all the time, but we're not yet generating a lot of theory. There is only one theory of paramedic practice, and that's Campo's space control theory. That's it. That's the only one. No other theory of paramedic practice exists in the literature that I'm aware of. And I challenge you, I'm laying down the gauntlet right now. If any of you can find a published paper about paramedic theory that's not written by Campo, I will give you something very special, to be determined. So put that on the forum. I look forward to finding something. And until then, think about this. Think about this presentation. And if you have any questions or feedback, definitely give it to me. If you want to give it to me privately by an email, wonderful. If you want to wait till the end of the session and provide feedback on the end of session evaluation, that's terrific. That's coming up right away since we're in our last module. And if you're thinking about something or if this resonates with you, put it on the Module 5 forums so that we can all chime in. As you can tell, this isn't something that really interests me. Thinking about paramedic theory seems really boring. And I'm sure that when you all looked at this, you thought, oh goodness, give me a break. But now that we've come through this, I hope that I've scratched the surface in making you a little bit interested in what this is all about. Because trying to find out and to identify what makes us unique as paramedics is absolutely, I think, fantastic.